Why did it stop? So it gives me great pleasure to introduce our grand round speaker today. Andrew Vandervaart is a PGY4 psychiatry resident in our physician scientist training program at the University of Maryland Medical Center and at Shepherd Pratt. He attended the University of Virginia as a Jefferson Scholar and obtained a BA in cognitive science. He worked for 3 years as a research technician in psychiatric genetics before enrolling in the MD PhD program at Virginia Commonwealth University School of Medicine in Richmond. His PhD dissertation was focused on the molecular pharmacology and genetics of alcohol use disorder under the mentorship of Dr. Michael Miles and Dr. Kenneth Kendler. During his clinical years in medical school, he became increasingly interested in psychosis and in novel psychiatric interventions such as neurostimulation. He started residency here in July of 2020, and soon after began spending his research time at the Maryland Psychiatric Research Center under the mentorship of Dr. Elliot Hong, who has patiently guided him through the foundations of neuroimaging and into a project using resting state fMRI to identify delusion-related neural circuits and potentially novel targets for TMS and schizophrenia. I have to say, in addition to his research ability, I was extremely impressed with Andrew that he chose as a PGY2, despite being in our research track, to take on a psychotherapy case in addition to our heavy PGY2 year. And I had the pleasure of being his initial psychotherapy supervisor. And I can tell you he's a wonderful clinician in addition to a wonderful researcher. So it gives me great pleasure to introduce Andrew for the grand rounds.
I'm trying out this travel microphone. Can you guys hear this? All right. I like pacing around, but I know that I can only go about this far because I care about the folks at home as well, and I don't want them to have an empty screen there. So thanks, Dr. E, for that kind introduction. It's a great honor for me to be a 4th year in the residency program directed by Dr. Ehrenreich, and also an honor to be able to speak with you all today at Grand Rounds. So thank you for coming. The title of the talk is Revisiting Delusion Subtypes in Schizophrenia Based on Their Underlying Structures. Now, I know that in itself sounds extraordinarily exciting, but in the spirit of Grand Rounds, I can say that the sort of clinical relevance here is the question of, is our lack of an understanding of the pathophysiology of schizophrenia limiting our ability to make treatment progress, right? So since antipsychotics, maybe really since clozapine was the last time we've had any sort of bump up to decrease our feelings of helplessness when we have patients come to us with schizophrenia. And I wonder if, given that we now have an increasing ability, at least theoretically, to target neural circuits with neuromodulation, if perhaps it's time to redouble our efforts to distinguish what neural circuits might underlie schizophrenia so that we can come up with some better treatment ideas, right? So here's another way of looking at the problem. If you go to UpToDate and read the article Schizophrenia in Adults, you will see this sentence: although the pathogenesis of the disorder is unknown, it is almost certain that schizophrenia represents a syndrome comprised of multiple diseases that present with similar signs and symptoms. Now, I have reason to believe that this sentence was actually written by our own Dr. Will Carpenter at the MPRC. Certainly, he was one of the contributing authors of this article. But the point is, this is the expert consensus, right? We don't know the pathogenesis, but probably there are multiple pathways that end up at this constellation of symptoms that we call schizophrenia. So let's make a little analogy. If we go back a few hundred years, there was something called dropsy, right? If you were a village doctor, someone might come in with generalized swelling and shortness of breath, and all you knew was that it was dropsy, and all you could really do was a bloodletting, right? Since that time, we've had EKGs, echocardiograms, and genetic tests that have revealed that what we once called dropsy was in fact heart failure, but heart failure itself is the sort of clinical syndrome that has multiple pathways that can get you there, right? Hypertrophic, dilated, preserved ejection fraction, reduced ejection fraction, et cetera, right? I'm not a cardiologist. Could it be that we're in a similar situation with schizophrenia right now? We are the village doctors who can recognize the syndrome, but we have the opportunity to use some tools to recognize the pathophysiology or multiple pathophysiologies. Now, of the symptoms of schizophrenia, I'm focusing on delusions. I think delusions by themselves are pretty heterogeneous. And we all have a sense of this intuitively. We know that there are delusion subtypes. In our checkboxes, we acknowledge this daily, perhaps. So you can sort of differentiate whether a patient is predominantly grandiose or persecutory. Are they hyper-religious? They have ideas of reference. And we sort of make a note of this. I'm not sure we do a lot with this information now. I mean, maybe some of us would say grandiosity might make us be thinking more about schizoaffective, some mania components to the psychosis. But other than that, maybe nihilistic is depression, right? But in terms of schizophrenia, we don't do a lot with differentiating delusions, but perhaps this is one of our inroads into differentiating pathophysiologies, which leads me to the hypothesis that delusions as a whole might empirically, like based on the data, group into clinical subtypes that then can be mapped to specific functional circuits. So let's start with this first part, and I'll tell you about some research we did at the MPRC over the past few years. So the question of whether delusions empirically subgroup. So how do you assess delusions? Well, there are these structured clinical interviews of multiple types, but I'm going to focus on the self-report, which we have been using at MPRC, the Peters Delusion Inventory. So the Peters Delusion Inventory is 21 items scored like this. So here's the first one, for example. Do you ever feel as if people seem to drop hints about you or say things with a double meaning? The participant or patient will score this on 3 subscales: distress, preoccupation, and conviction. So then for each of these 21 items, they get a severity score for item 1, for item 2, et cetera. The first question was, if we take these 21 items, can we reduce the dimensionality such that certain items are going to be commonly correlated, essentially, right? That if you're high on item 1 and that's about a certain theme, maybe you'll be high on item 4, if that's also about a certain type of delusion, right? So that's the first thing we're going to talk about. Then we'll get into the part B there. So this is an exploratory factor analysis. I don't know if everyone can read this, but here are summaries of the 21 items. With this factor analysis, you're essentially finding those items that group together in a given patient. If they're high on one item in factor 1, they're probably high on the other ones. And you can see that there's these shared themes. Factor 1 is generally about paranoia. Factor 2 is grandiosity or hyper-religiosity. Factor 3 is an interesting one to me. I would call it selfhood disruption. So it's things like thought insertion, thought withdrawal, external control. So all things that are about not being able to differentiate self from non-self. And I would say this is what Kurt Schneider was talking about when he talked about first-rank symptoms back in the 1930s, the types of delusions that indicate that the patient is not recognizing themselves as distinct from others. There's a boundary breakdown there. So that's selfhood disruption. And the last, low self-worth, is delusions of jealousy, guilt, and people looking at you oddly because of your appearance. So things that are sort of related by this sort of low self-regard, I would say. So now we have, sorry, can you? Right. So these are 286 patients that have diagnoses of schizophrenia or schizoaffective disorder. So they were given a formal structured interview for the DSM. So a delusional disorder diagnosis would not be included here. Would be an interesting question for a similar kind of study, but these are schizophrenia spectrum patients. All right, so now that all 286 patients now have a score on 4 things. They have a paranoia score, a grandiosity score, selfhood score, and low worth score. We're now going to see among these 286, are there similarities among patients? So we look for similarities among the items. Now we're saying, are there certain patients that all share qualities in terms of their score on these 4 factors? So this is a cluster analysis. Essentially, you're This is really done in like 4-dimensional space where each axis is one of the delusions. I couldn't make a 4D figure. I was really struggling with that. Just kidding. So I'm showing it as a 2D figure here. So if we look at paranoia on the bottom axis, you can then look at where patients tend to show up on these other three compared to where they are on paranoia. And the point of this is really just that for grandiosity, when we look at grandiosity, there's this cluster of dots that I've now colored blue that are low on paranoia but high on grandiosity, whereas with the other ones, there's kind of a paucity of dots in the upper left. Each dot is a patient, meaning that if you're high on paranoia, you're probably also high on selfhood disruption and low self-worth. But there are some patients that are only high on paranoia and some that are only high on grandiosity. So we call these low delusion if they're low across the board, paranoid predominant, grandiose predominant, or pan delusion if they're high across the board. All right, I feel like I've been peddling these wares for a while now. So if this is like your third time seeing this stuff, I apologize. We'll get to the new stuff too. This is to say, remember these groups we came up with, these delusion subgroups, were purely based on a self-report about delusions. What these are clinician-based assessments, right? So the question is there any clinical validity if a clinician looks at these patients and ranks them on things like anxious depression, hostility or suspiciousness? Do we see any differences? And we do see significant differences. So for anxious depression, pan delusion, which includes the low self-worth, for example, delusion is the highest, then paranoia and down to low delusion. For hostility and suspiciousness here on D, you can see that while low delusion and grandiose predominant don't have a lot of that, paranoid and pan delusion do. But this is also not always just going to be a severity scale where low delusion is the least severe and pan delusion is the most severe, because we have the brief negative symptom scale there in F, where in fact the low delusion group scores the highest on negative symptoms, indicating that that low delusion group may in fact be a sort of negative symptom predominant subset of schizophrenia patients and not just people that tend to rank things low on self-reports. A few other interesting findings. So paranoia was actually, the paranoid factor was positively correlated with cognitive functioning. So we had these two cognitive tests, working memory with a digit symbols test and processing speed with digit sequencing. And the paranoid predominant group had the least impairment, meaning they performed the best on these cognitive tests. And the paranoid factor across all patients actually predicted a higher score on these tests, which I was a bit curious about when I had this finding. And then I've presented this at conferences, and I've actually had psychiatrists tell me that they've recognized a paranoid schizophrenia subtype of patient that does seem to have less of the long-term functional decline compared to other types of schizophrenia, which of course in prior DSMs may have been called differentiated schizophrenia or hebephrenia way back in the day. So it's an interesting enough finding in terms of there's clinical consequences, I think. A few other things that for whatever reason, the grandiose predominant group had the highest degree of nicotine use in terms of cigarettes per day. And the paranoid predominant group had the highest lifetime prevalence of cannabis use disorder. So here's kind of a summary. And really the point of this is that, remember the question we were asking, if you start just with delusions and you subtype them and subgroup them into patient types, do you see actual differences in the real world based on this? And I think you do. Again, the low delusion group seems to have more impairment and negative symptoms. The pan delusion group, pretty severe across the board. Paranoid predominant with that sparing of functional impairment. So, how are we doing on time? Let's get to the second half of the hypothesis. So, can these delusion subtypes be mapped to specific functional circuits? So now let's just focus on the factors. So those patient groups, paranoid predominant, et cetera, you can forget about those right now because we're just going to take 74 patients and we're just going to look at their paranoia score, grandiosity score, low self-worth score, and selfhood disruption score. If we had more power, we could actually look at the different patient groups, but for now, we're just looking at the, we're just looking at the delusion severity scores. So first, let me just go through some schizophrenia neuroimaging literature review. So I would say that the neuroimaging findings of schizophrenia to date are indicative that this is a disorder of disconnectivity. And so there are a few ways to look at connectivity. One is looking at structural connectivity, for example, white matter. This is a large study of actually first episode patients. The red there is all decreased white matter integrity, indicating a sort of overall hypoconnectivity of myelination throughout the brain, right? And specifically with delusions, there are some indications that patients with active delusions, that's what the group on the far right, has kind of the most severe impairment along certain white matter tracks. Here they looked at the left and right cingulum bundle and found that delusions showed a further worsening of white matter deterioration. I'll skip that. Okay, the other way to look at connectivity is functional connectivity. So this is about brain activity. And so these are patients that go into a functional MRI. They're in there for a period of time. You take the time course of activity in all of these brain regions, and then you look for correlations between brain regions. When one's high is another low, that would be negative functional connectivity. When one's high is the other high, that's positive functional connectivity. Or is there no relationship? That means there's not functional connectivity between regions. The other thing about this study is they're looking at networks, which we increasingly tend to do. Rather than look at brain regions, we look at functional networks. And so the overall point of this is that the blue is decreased functional connectivity. So in line with the predominant pathologic hit being global disconnectivity, we see that both on the structural level and on the functional level. The exception to the decreased functional connectivity, if you're interested, is actually the affective network to the ventral attention network. Those are the ones in red there. They have increased functional connectivity, possibly indicating a kind of aberrant salience that there's a hyperconnectivity between affective states and attention in patients with schizophrenia. All right, so let's get back to the research we've done at MPRC. So 74 of our schizophrenia spectrum patients went into resting state scanners, and we did a network-based analysis. So resting state means they're in the scanner for 20 minutes. They're not doing any particular task. They're just wakeful. They're in a state of wakeful rest, and we're looking at the activity throughout the brain. What we do is we actually parcellate the brain into 246 subregions. So there's 246 nodes where we're tracking the activity, and then we're going to correlate the activity between all 246 regions with all of the other 245 regions in each case. Looks like this. And this was actually essentially it's a big correlation map. Technically it's regression, age and sex were covariates, but we're looking for cases where a pair of brain subregions of the 246 have a connectivity that is correlated with a given delusion factor. So I'm showing that this is for paranoia, for example. What we end up seeing in the network analysis is two clusters of hypercorrelated regions, meaning hypercorrelated pairs of connectivity between regions with paranoia. Okay. And then we do that. We take these two subnetworks and we map them onto the brain. Okay, so this is paranoia. This is grandiosity. This is selfhood disruption. And this is low self-worth. So I think I've made my point. So we can look at some things quickly here. So for paranoia, what you see is a kind of frontolimbic. So that's the red to yellow there are nodes in the frontolimbic regions, and then some parietal up there in green. Grandiosity has this pretty tight network of insula subregions with the inferior frontal region there, and then another kind of frontotemporoparietal network. Selfhood disruption has this cluster right along the inferior frontal gyrus and well into the insula as well. So the deep brain structures there. And low self-worth just has one subnetwork with more nodes, but seems relatively midline down the brain. Involves the deep structures and then radiates out in each direction from the deep brain structures. So if we can compare all of these, this is the kind of bird's eye view of the differences between our networks that are implicated in these delusions. Another thing to look at would be just how much overlap is there between these. You know, it's kind of hard to tell here how much overlap. So if you just count the nodes or subregions that are overlapping between the different networks, you can see, for example, you know, paranoia and grandiosity have an overlap of 13 subregions, whereas grandiosity and low self-worth has the lowest, that only has 6. So in terms of kind of face validity, I mean, if you think of grandiosity and low self-worth as being maybe the most differentiable on a clinical level, they're also the least overlap in terms of the brain node. So somewhat reassuring there, I would say. But in terms of what these things mean functionally, I'll admit it's kind of hard to tell, right? We're not machine learning algorithms. So we have to figure out what this means. So one thing I did was I looked at some known functional networks. So when we talk about functional networks, we're talking about circuits, collections of subregions, pathways of the brain that are involved in a certain function. So these have been annotated variously throughout the literature, but so things like the default mode network, the function there is being in the default mode, meaning wakeful rest, not doing anything else. Attention networks are engaged when you're paying attention to a specific task. Affective networks are engaged when you're doing something affective. For our purposes, I was interested in the attention network. There's actually 2 attention networks. One is the dorsal network, which is it's involved in executive tasks where it's what they call top-down attention, meaning you have some cognitive control of attention, you have some volition over your attention. That's distinguished from the ventral network, which is both deeper in the brain and distinguished by being bottom-up attention processing, meaning when something gets your attention, it's not up to you, gets your attention, the ventral attention network is activated, right? So if we let's just take the attention networks that we know from the literature, the things that have been annotated as attention networks, let's put them onto the brains, and then let's highlight which subregions from each of our delusions also show up. So we've got everything in red is a dorsal attention network node or subregion. Everything in blue is a ventral attention network node or subregion. Where it's highlighted means that node is also in the corresponding delusion. So for paranoia, you have these more surface level nodes there. You have no highlights in the blue. Also no highlights of the ventral attention node for low self-worth, or maybe there is one there. But for our purposes, the difference between the blues is what sticks out to me. So that grandiosity involves these multiple regions of the insula, and selfhood disruption actually reaches statistical significance in terms of being enriched for nodes in the ventral attention network. So if you do a Z-test for comparisons, there are more than expected ventral attention network nodes in the selfhood disruption network, which I would say somewhat speculatively at this point, but that the selfhood disruption delusion is a deep hit, right, to the brain. It's about that loss of self versus other. And so if you think about where that boundary might exist between self and other, could it be deeper than the hit that hits the attention of people with paranoia? They're selectively paying attention to things that are in line with their delusion, whereas people with a selfhood disruption hit have this kind of fundamental disturbance to their experience of self. So to me, it lines up with that idea. There is more we should do with this. But the other thing I think that is pertinent to think about is TMS targets. So the targets that are currently used for TMS most often, and really in depression is where you see this, are the dorsolateral PFC, which when you look at the paranoia subnetwork, I think would be a reasonable starting point. There is that prefrontal to limbic circuit involvement there, whereas the another one would be the temporoparietal junction, which to me looks like grandiosity down here. TPJ could work for that. Whereas selfhood disruption and low worth, well, low worth actually might have that some ability of the dorsolateral PFC. There are those inferior frontal nodes there. But for selfhood disruption, it might be one where we want to look at what's coming down the pike, which is these new coils for TMS that are at least purported to target deeper structures. So like an H coil is arranged so that the penetration goes further into the cortex. So if I were going to do a trial right now on TMS with the sort of previously established targets, I would probably select or determine whether there was, I would hypothesize there's more success for maybe paranoia, maybe low self-worth for that current DLPFC target. Whereas if we could get an H coil and start figuring out how to get down to the insula, I would do that for the patients with selfhood disruption. All right, so what have we talked about? We've talked about some potential clinical utility of just subtyping patients based on the reported delusions, even self-reported delusions. For whatever reason, there's this increased tobacco use in patients with grandiose predominant delusions. Could hypothesize maybe that's because they have a kind of idea of invincibility, or perhaps they're self-medicating with tobacco, but those are speculative right now. Potentially better prognosis for paranoid predominant, as I've heard from psychiatrists, and then those sort of pathophysiologic principles I just talked about of neuromodulation targets, and just generally, trying to figure out if these might be analogous to preserved ejection fraction, reduced ejection fraction, hypertrophic, restrictive, dilated. Seems like it's worth a try to me. So I want to thank everyone who made this possible. First and foremost, the research participants at the MPRC who cooperate with these often long and arduous tasks. My mentors, Dr. Hong, Dr. Adhikari, Dr. Aronson at Shepherd Pratt, the statisticians and the others at MPRC that have provided much help and guidance along the way, the PSTP program, Drs. Gould and Ehrenreich, my committee, my co-residents, and all of you for paying attention to this talk. Thank you. Dr. Ehrenreich.
So it's interesting to me that back in the day when I was a resident, but we were taught back then that paranoid type of schizophrenia started later, and more about cognitively and also interpersonally.
Yeah. So in case people couldn't hear that, Dr. Ehrenreich was observing that in the DSM-3 there was the official paranoid schizophrenia subtype that, and the official teaching, was that there was less interpersonal impairment and functional impairment. And it's interesting that this kind of lines up with what we're finding here. And that's sort of where revisiting delusion subtypes in the title came from. And I went back and read some of the literature from like the 70s. And I think maybe what I would guess is the kind of dispute between paranoid schizophrenia being distinct and not, is that there are some patients who start out in paranoid schizophrenia, but then deteriorate further. So they start out with paranoid predominant delusions, but then they have a kind of progressive process. So it sort of reminds me of like the dementias, that the dementias all have a final common kind of pathway, but how you get there matters. And so for paranoid schizophrenia, I would wonder if sometimes it's a step along the path and sometimes it is the endpoint.
food proposal. What happened is, as other studies have done, as patient has completed a resource, they're not staying in one company, they're moving from that's why we just fired. They're already taking one on substance. Because one admission is the predominantly paranoid, other admission and the other admission. So that is one of the classification.
Yeah.
Even now, I think it's about
Thank you. Dr. Colt. The question of with the association between cannabis use disorder and paranoid predominant schizophrenia that I've shown here is can I say anything about the causality, or do I have a sense of the causality, i.e. whether it's a self-medication kind of thing where the patient with paranoid predominant schizophrenia uses marijuana at a high rate because of having the paranoia already, or could it be causing it? I certainly can't say based on this study. I mean, what we did with the cannabis use was a retrospective kind of thing, and it's hard to get a timeline on retrospective symptom reporting, I would say. It would be we could do a study that would be correlational, but we couldn't control it, I guess is what I'm saying. My personal sense is that because paranoia is a not uncommon side effect of cannabis, it would seem strange to me that a patient was self-medicating paranoia with cannabis. But I recognize that that it's not necessarily affecting all people in some ways, and certainly there are many patients that report that it decreases their anxiety. So my personal sense is not empiric at this point, I guess I could say. Although there are other studies that I also think make a pretty good argument for a causal role in schizophrenia, of cannabis and schizophrenia generally.
This is Will. Are you able to hear me?
Hi, Dr. Carpenter. Yes.
Yeah, hi. I'm remote, so not sure quite how to do this. Just a quick one very, very interesting work, and the way
Thank
you
you.
presented it, I appreciate that. I was wondering about the transcranial use. When you identify the target, how do you determine whether stimulation is a good thing or a bad thing for the target?
Right. And I think maybe unfortunately, I think a lot of the time you only end up finding that out empirically, but by doing the study, because the general principle is that if you're stimulating at a higher rate than the basal rate of neural firing, you're going to end up stimulating the circuit. And if you stimulate at a lower rate, essentially you're inducing a synchrony with whatever frequency of TMS stimulation you're giving. I think in practice, it's found that there's often disparate effects in terms of what even your intended stimulation or reduction from your TMS does. I think it essentially needs to be borne out. I mean, what I would love is if there was just a huge database of just healthy participants that came in, got TMS at different sites, monitored what the circuit level responses were at all of these different sites at a bunch of different frequencies. So then we could almost have like a reference for what you might expect to happen when you stimulate. But the other complication in this point is that we're essentially looking at networks that are aberrant, but we haven't parsed out, how much of each of these delusion networks are hypo-connected relative to healthy controls and how many are hyper-connected. We just know that there's an implication here that the circuit is dysregulated because the strength of the connection is correlated with the delusion, but that connection could either be positive or negative because we're essentially taking the absolute value of the connection. And it's a hairy knot too, because when hyper-connected systems like the brain, there's so often compensatory changes. When two things get more connected, something else will get less connected. So it is a pretty sticky wicket, to use a technical term.
Thank you.
Hi, this is David Gorelick. I'm also remote. I don't know if you can see
so are
the
we-
hands raised on
So
your
I think
screen.
we need a microphone. Hold on. There was a question being asked here in the
Oh.
room. I'm going to use this portable mic and give it to you. 1 second.
I'm trying to simplify the whole thing, even though it is not so simple. The areas that are exposed, because transcranial magnetic stimulation, only the stimulation can go as 1 centimeter to 3 centimeters deep. You cannot go to every other structure. So if it is high frequency, that is 10 hertz, 5 to 10 hertz or more, it has excitatory effect. If it is low frequency, 1 hertz, it is inhibitory effect. So then you use the combination, the area right and left. There are several combinations and permutations. You can come up with different strategies. Am I right?
Yes, thanks, Dr. Doty. Dr. Gorelick, please go ahead.
Yes, thank you. Very, very stimulating presentation, if I can coin a phrase.
Thank you.
So I started my psychiatric training in the era of DSM-2. I also was in the medical scientist training program, which they had back then. So one of the things we learned is that the content of delusions are also culturally influenced. I can't cite you the studies. I don't remember if they're still considered valid even, but at different time periods and also in different countries, you know, the content, whether they're paranoid or grandiose, you know, might vary. One, is that concept still considered valid? And two, how would that possibly influence or bias your categorization of the types of delusions? In other words, would your findings hold in different countries?
Right. No, so that's a good question. And yeah, certainly I think with the time periods, you can have differences where demon possession was much more commonly reported in religious cultures, whereas alien abduction is much more commonly reported now, or whatever these sort of I think you know what I mean, right?
Right.
What I wonder is if the quality of the delusion might be less culturally based than the content of the delusion, but that's more of a personal sense. But basically, meaning if you have a paranoia subjective state and then you apply it to something that makes sort of cultural sense to you, the differences will be in the story, but not necessarily in the quality or the kind of affective valence of the delusion. But of course, the better thing to do, or the important thing to do, would be to just empirically test for cross-cultural differences or commonalities. Yeah. Yes.
Thanks. Andrew, I wanted to echo the comments. This was an incredible talk. Great job. I had 2 questions. The first question is just from my perspective as a humble clinician, that I think as clinicians, we are often quite horrible at eliciting delusions. And so I know you talked about the implications of this work towards treatment, identifying prognosis, but could you say where you think this work might also help with earlier identification and being able to figure out who is experiencing these types of things? Because by interview, we're still pretty poor. That's my first question. My second question is just generally, and I think folks probably know that Andrew is quite the unicorn. We have less than 2% of physicians engaged in research activities as part of their day-to-day jobs. So first of all, I wanted to just say we should give him a big round of applause for that, because it's a hard thing to do. Thank you. But I'm just curious your perspective after going through this, what your thoughts are as a PGY4 about the need for physicians to engage in the research process and what the unique contributions of physicians are to that process. So first thing is about how to use this to improve eliciting delusion or diagnosis, and then the second about your perspective.
Thank you. Thank you. So certainly the dream is that one day a patient that comes in can actually go into a functional MRI scanner and will have these circuits so well mapped out that we could identify, what their physiologic state is that would, underlie a given type of delusion. And, I guess I don't know if it's good to call it a dream to sort of be able to bypass self-report eventually, but I do think most of the rest of medicine tends to do that. They hear what the patient says, they decide what tests to give based on that, but the diagnosis is based on what the lipase level is, right? So that would be the dream, that one day these things are distinguishing enough or differentiating enough that it could be part of the diagnostic process, in addition to part of the treatment process for those patients that are sort of engaged, telling us things and willing to participate, right? Okay, and in terms of so my experience of physician science is, I love it. And I think it's definitely kind of a shame that I feel like being a physician in the modern world does have a lot of demands that would make it very difficult for someone who didn't have like dedicated time, as I'm very grateful to have here, to do research. It's hard even for me to imagine, and I love doing research, but there is so much onus on physicians to do so many things kind of administratively that I sympathize with the fact that it seems very difficult to do. I do think it's very important because I think physicians will have unique benefits from sort of directly engaging with the research. There's an old term like grokking. If you grok something, it means to like fully comprehend it, like on a personal level. So to have that kind of like direct experience with what the research finding means, I think makes it more applicable, makes it more part of you than if you're just reading it kind of sterilely. And I also think they have the ability to make unique contributions, because what can happen in, I remember my graduate school days, and there's these brilliant scientists, but they can become kind of increasingly far afield from sort of the question of like what's going to get people out of the hospital. You can get very zoomed in on like whether this kinase gets phosphorylated at this time or whatever. So I think knowing what questions to ask does often come from clinicians, and so it would be important for that reason. Yes.
So these are all.
Yeah, well, it's all patients with a schizophrenia spectrum diagnosis. So they've had delusions at some point in most cases, but technically they could have had the diagnosis without delusions if they had the hallucinations and disorganization.
Some people talk about this.
Sorry, I forgot that people can't hear your question.
So these patterns of activity seem to relate more to the maintenance of delusions, because the delusions are established and they're basically they're fixed. It's about the fixedness of the delusions. So my question is, one, is that how you see it? And two, what does that say about the clinical utility? You can sort of see TMS silencing a voice in your head potentially, but it seems very hard to undo a delusion. So it's hard to know what the therapeutic outcome of TMS for delusions would be. Do people stop believing things that they believe for 20 years? That sort of thing.
Yeah, so that's a great point and a great question. I definitely think there is an important distinction between delusion formation and delusion maintenance. You know, my personal hypothesis would actually be that during delusion formation, there's a kind of hyperplasticity of the brain. And then once it crystallizes, there's a hypoplasticity that makes the delusion so fixed and underlies the maintenance of delusions. But I also think there's a difference between kind of like having an active delusional experience that makes the delusion sort of front of mind compared to them just being crystallized somewhere in the brain, but not interfering with functioning so much. So that would be the goal of TMS, would be to decrease the kind of distress and preoccupation with the delusion, but the belief might still be there, at least after even acute successful treatment. They may still have the belief, but if they're bringing it into their awareness or involving it in their life less, that would be a success. I could go further and say I might hope that if you could maintain remission of the distress and preoccupation of the delusion, it may sort of fade out of their belief system eventually. Yes, Eric.
Was there any, did you check out that score that you were saying, the, what was it, the like distress and like front of mind and preoccupation and all that? Do you think there might be any, like with the tightness of these circuits and stuff, would there be any change based on how intense they score on those? Yeah.
Right. And so another good question. And in fact, so this discussion is giving me ideas. So thank all of you. So what we did was these are total scores based on the distress plus preoccupation plus conviction. I do think, especially if we were looking for TMS targets, it might become more important to maintain those subscores rather than use the total score, because what I'd really be interested in is if we ended up successfully targeting any one of those things, that would provide a lot of meaning, I think.
Just make a couple of comments.
Dr. Dodi, just a couple of comments about some of the things that were discussed. As far as the cultural thing, it was interesting because, again, pre-DSM, DSM-2 was there at that time. DSM-3 just was formulating, Bob Spitzer and the group. So I went to India on vacation as a PGY2 resident. So in those days in India, there are no psychiatrists. And once they heard I'm getting training, they brought up the family members or others. The interesting thing I learned is if somebody is CIA is after me here, there they say this particular priest or particular sannyasi they call, whatever, is put a voodoo on me or voodoo type of thing. Even though you can see are the grandiose, I'm the king of this particular province because Rajas are there. So you can still, even though it is culturally different, you can still see the same themes. It is really interesting for me because I only got the training here. I never had any psychiatric experience before. So second thing is how to improve our critical things. Yes, for me, the interview are able to dissect the symptoms came because I was fortunate to, as a junior most attending, to do clinical research on schizophrenia. I don't want to go into the study, which changed the whole practice, but I did 600 SCID-1 interviews, which helped me really to ask the right questions to the right person. It gave me the idea it is not just person has delusions or no delusions. There are different degrees. Same thing with hallucinations. I think it also helped me to read the journal articles, to listen to the salesman and know what they are saying, really tease out, and also know the ambiguity in research, which is much more, gives you much more better clinical perspective.
Thanks, Dr. Doty. As we say in lab, that's a lot of skids. All right, well, thank you all so much. Great discussion. Really appreciate it.